modification using twin blocks. All right, so today's presentation is going to be about integrating growth modification with twin blocks into clear aligner therapy. I'll give a little bit of background about, functional appliances, when we want to use them, just really briefly, and then translating those concepts into clear aligner therapy. And I'll do a little demo showing you how to set that up on Titan. And I'll show you kind of what happened with the case in real life. So this is basically how a twin block in general works. We kind of use this video for patients. So it's basically a traditional twin block is like an upper retainer and a lower retainer with two blocks and an expansion screw. The reason we need the expansion screw is that as you bring the lower jaw forward, you have a wider part of the mandible, occluding with a narrower part of the maxilla. And so we need to widen the maxilla a little bit to accept the mandible in a more forward position, just like in a surgical case as well. So the way that the blocks work, when the patient bites in the class 2 position, the teeth don't come together unless they slide forward, as you can see in that video.
Oh, Mohamed, sorry to interrupt you, but for some reason, a windows of Zoom appears in your screen. I don't know why.
What's appearing?
Windows of Zoom. My Zoom is appear as a square inside the presentation. Yeah, there you are.
Sorry, tell me what's appearing, because I can't see what you're seeing. Sorry.
That one, close that one, yeah. And now present it. Oh, yeah.
So let's try that again.
Yeah.
It's,
yeah, there you are. Perfect.
Okay, great. Sorry. Okay.
You're welcome.
Go.
All right. So, as I was saying, it's an upper Hawley, lower Hawley expansion screw, two blocks that are designed to fit together in a class 1 position. So we would take a regular so you'd scan the Jose, I think I can hear you.
Yeah, no, I try to mute the people here. People, please, the microphone off, please, during the presentation. Okay, go ahead.
So we'll scan the upper arch and we'll scan the lower arch, and we take a bite registration in a forward position. That's how we used to do it. And then the lab will fabricate the appliance in the forward position. We used to do that with Titan as well, but now we just take the bite in the class 2 position and just virtually advance. But when we used to use a twin block, a traditional twin block, we'd scan the upper, scan the lower, take 2 bite registrations. On the Itero, you have the option to pick 2 bite registrations. We take 1 bite registration in the class, in centric occlusion with the patient in class 2, and take a second bite with them a little bit more advanced. And sometimes there's a limit to how much you can do that because the upper teeth are retroclined. But, sorry. I just want to show something here a little bit later in this. So the lab would fabricate it with the patient in class 1, if it's possible, if the teeth allow you to. And they bite in the class 2 position, and the teeth don't come together unless they slide forward. And ideally, I'd like them to come even a little bit more forward than that, so you can activate the twin block by adding more acrylic to bring them more forward. I generally don't like to bring them more forward than edge to edge. If anything, I prefer to bring them less than edge to edge so that the upper teeth prevent the eruption, the advancement of the lower. And that part is really important, where you trim the acrylic on the upper component to allow the patient to tripod. So we trim the acrylic from the upper component to allow the molars to erupt. I think that when you first get that skeletal change, if the patient's growing and you bring them forward, if you don't give them a posterior stop, I think you tend to relapse a lot more easily. So I wouldn't take the twin block away from them as soon as they're class 1. When they're class 1, you want to trim the upper component of the twin block, allow the molars to erupt into class 1 so that they have a stop. I think the new bone that forms in the condyle and the fossa is, in the beginning, I think it's not very mineralized, and if you don't give them an occlusal stop, it tends to relapse and resorb. If you give them a posterior stop, they've got something to support that new bite. And this is kind of opinion. It seems to cause a lot less relapse if you give them a posterior stop. And this is some kind of evidence supporting, when we should do this. In the old days, they used to treat patients really early. The traditional Tulloch and Prophet papers showed that treating patients with twin blocks early, before the growth spurt, they used to do it at 7 and 8, just generally wasn't as effective. You'd get a little. So this is from a Cochrane review, and it shows the top portion of this. Let me just find my mouse here. For some reason, that's not showing. But usually I can point. But with the zoom functionality, I can't access my pointer. Anyway, the first group of papers here, the prepubertal ones, that shows changes to the mandible when they follow the patients up till the end of phase 1 and phase 2. There's a very small change to the mandibular length. On some studies it was significant, some studies it wasn't. Probably neither of them were very clinically significant. It was less than 2 millimeters. Whereas when they treated patients during puberty, there was a much more significant skeletal effect. And this is a forest plot here. And you can see the black diamond shows the combination of all those randomized clinical trials that showed that there was a very small effect when they were treated before puberty. But if you treat with a functional appliance during puberty, you get much more, a much greater increase to the mandibular length. This is another forest plot showing the changes in the ramal height. I think you get a lot more chin projection and a much nicer skeletal effect if the ramus grows more. And you can see the prepubertal studies at the top. There's no significant change to the ramal height, whereas when you treat during puberty, you get much more increase in the height of the ramus. This shows a comparison in the Cochrane review of fixed functional appliances versus removable functional appliances. And it generally shows that removable functional appliances are more, you get a bigger skeletal effect. This is changed to the A and B. I think both of them will affect. The study actually shows that the overjet is pretty much the same whether you use a fixed or removable functional appliance. Maybe even a fixed function will be more effective at fixing the overjet. But if you're looking at it from an A and B skeletal point of view, the fixed functional appliance doesn't have as much skeletal effect, not as much of an effect on the A and B angle as a removable functional appliance. And I think a lot of that is due to the fact that the fixed functional appliance is going to move the teeth, and the teeth are going to move before the patient can grow. So you get the dental effect quicker, but as a result of it, you're not in it for as long because you haven't prevented the dental compensation. You haven't prevented the proclination of the lower incisors. So the overjet's going to decrease before the patient gets the chance to grow. With a removable appliance, you have a little bit more control over that. I think you don't get as much proclination of the lower incisors, especially if you control it with a labial bow with acrylic or with the aligners. You can prevent those lower incisors from coming forward, and you can advance the upper incisors, kind of decompensating them and allowing the functional appliance to work a little bit better for longer. And this shows a comparison of twin blocks versus other functional appliances. And you can see here that the effect of a twin block, you can see it slightly favors a twin block over the black diamond shows that the effect on the overjet is insignificant. But the final A and B angle, when you combine all those studies, it does show that the twin block may be a little bit more effective than other functional appliances, probably because you can control the vertical and control the lower incisors a little bit better. And to determine when the patient is in puberty, usually you want to use either a hand wrist radiograph or the cervical vertebra on cervical vertebra maturation from the Seth. And generally, you want to start when the sesamoid stage 4 appears and before stage 8. So after stage 4 and before stage 8. So before you get fusion and after the sesamoid appears. And that's the stage, those are the stages we call capping, 5, 6, and 7 there, where you see the epiphysis and diaphysis not fused, and you see those horns pointing upwards. And this kind of shows you the decision tree when you're looking at this. If number 4, if the sesamoid is present, then they're not prepubertal. If sesamoid is not present, then they're prepubertal. Sesamoid is present, then they're either pubertal or postpubertal. And to figure that out, you look at stage 8, the distal phalanx of the third finger. You see if it's fused. If it's fused, they're postpubertal. If they're not fused, they're still in their growth spurt. And here you can see, this is just an example. These are the same X-ray, just made it a little bit bigger. You call the sesamoid stage if you see any signs of calcification. This is a very, very early stage 4, where the sesamoid is just starting to calcify, and you can see the epiphysis is as wide as the diaphysis, and you may see a little bit of capping that's thinking about happening there. Here you see the sesamoid is clearly present. So they're either pubertal or postpubertal. And you look at stage 8, the distal phalanx of the third finger, and you can see that there's no fusion there. So they're towards the end, but it's getting close to having fusion. So it's towards the end of the growth spurt, but they're not finished with the growth spurt yet. And here you can see the capping, these little horns between the epiphysis and the diaphysis. And for cervical staging, it's not as accurate as the hand wrist radiograph, but basically between cervical stage 3 and 4 is where the spurt happens. So you want to look at the shape, and you want to look at the curvature of the C2, C3, and C4. And you start out with all of them being flat, and then you get a curvature under C2, which is cervical stage 2. In cervical stage 3, you get a curvature under C3. Cervical stage 4, you get a curvature under C4. And then to tell the difference between 4, 5, 6, you look at the shape. And the shape starts out as horizontally rectangular in stage 4, and then at least one of them is square, making it stage 5. And if at least one of them is vertically rectangular, that makes it stage 6. So the growth spurt happens in the year following cervical stage 3. So when you have a curvature under C2 and C3, but not C4, and they're kind of rectangular, horizontally rectangular, that's kind of when the growth spurt is happening. Here are some examples that show the curvature under C2 and C3, and C4 is still flat. So this person's starting their growth spurt. So here's an example of someone that got a traditional twin block. And you can see you have the sesamoid present, and you've got just the beginning of capping. So this is a good stage for her to start. I like the shape of the symphysis. When the symphysis points forward like that, if they're in their growth spurt, they seem to be good responders. Another good thing to look at is the ramal angle. When the angle of the ramus, the angle between the gonial angle, when it's more open, they tend to respond a little bit less. The more closed the gonial angle, the better they respond. And kind of Bichetti showed that in an article. And this is what it looks like at the end of the twin block step. So there are no braces here, just the twin block. I made sure when we advanced her, we didn't advance her beyond edge to edge so that the upper teeth can keep the lower teeth in check. You can see her upper arch was expanded with the twin block. And you can see that we trim the acrylic from the upper component to allow the lower molars to erupt. And you'll see how we'll do that in the aligners as well. But you want to get the molars to be in occlusion before you stop the twin block. And at this point, we discontinued the twin block and we just let her go until, and we let her go for a few months. And this is kind of what it naturally looks like. Premolars erupted into class 1. There's nothing, no intervention between here and there. You just let them go and the premolars erupt into class 1. And at this point, it's a much easier case to deal with. You can argue whether you want to take premolars out or not, whether it's a braces or an aligner case, but it's a much better position to be in. Even if you wanted to take out 4 premolars, at this point, the canines and molars are class 1 and you have that option. Whereas before correcting the class 2, it's tough to extract lower premolars when the patient's full cusp class 2. And here's her progress, Seth. And you can see it had some skeletal change. So this is the patient I'm going to show you today. She's class 2 div 2. And let me go to her setup here. So this is in Titan, and you can see that we integrate with iTero. So I'm going to pick the initial scan, which was May 2023. So she's been in treatment for about under 2 years. And I'll show you how we'll set her up. So you can see she's full cusp class 2 division 2. This is really hard to do with a traditional twin block because you don't have the clearance, you don't have the overjet. You would need to do put a 2x4 in, start out proclining the upper centrals, and then put a traditional twin block in. If you're doing it with clear aligners, you can gradually bring her forward, and I'll kind of show you how to do that. As the upper centrals are coming forward, you could gradually bring the mandible forward. You can see it bilaterally full cusp class 2. You've got that crowding in the upper with the retroclined upper incisors and not much crowding in the lower. She actually has a pretty nice looking lower arch. So I'll just take you through the steps. So this kind of automatically locates the teeth. The teeth, you can adjust it if it missed something or you want to adjust the position, you can do that. Same thing here. It automatically picks the points of the teeth. The AI picks it and you can adjust it. You go to the segmentation step. And this is acting a little funny. Let me restart it. Nope. Yep. May 22, 2023. All right, so this is the auto segmentation that's happening. And I included the palette here because I want to do some expansion. So if I'm doing some expansion, I scan the palette. So I include the palette in the segmentation because I want the aligners to cover the palette so I can get a little bit of maxillary expansion. And I'll also use thicker plastic. If I'm doing it with the traditional vacuum form, I'll use 1 millimeter. I'll use 1 millimeter plastic instead of the traditional 0.7. Or if I'm directly printing, I'll print it 1 millimeter instead of 0.6. The way we'd normally print if we're doing direct printing. We'll get to that in a little bit. But the auto segmentation looks pretty good. I'm going to check the mandible. That also looks pretty good. I don't really need to make any adjustments, and usually it's good, but sometimes you need to go in there and fine tune it. And to fine tune it, if the gingival height isn't correct, you can extend there. If the tooth extension isn't correct, you can just click the tooth, grab the tooth, and extend it to the correct periphery of the tooth. Okay, it's identifying the teeth. And again, if it's not correct, if there's a missing tooth or whatnot, you can just adjust one tooth and it'll auto-correct the rest of the teeth. Same thing in the mandible. It identified the teeth correctly, which is fine. This is where you're correcting that long axis of the tooth. And this usually needs a little bit of adjustment. The importance of this is that when you adjust it so that when you click mesial, it moves, the tooth moves mesial. So when you're doing the 3D controls in a little bit, you want the axis of the tooth to be correct. Otherwise, when you click mesial, it's not really going to the tooth's mesial. I think here those molars are a little bit rotated. That can be adjusted a little bit. And I'm looking at those roots as well. All right. So here you also have access to a Bolton analysis. This tells me I've got 1.8 millimeters of mandibular excess, 3 to 3. That's useful information when I'm doing this setup. And you can kind of decide whether you want to do the IPR during the first round of aligners with the twin block so that you can get the patient closer to class 1, or do it later. But you know that if you don't address that 1.8 millimeter tooth size discrepancy, even if you procline the upper teeth, unless you open spaces distal to the upper twos, you're not going to be able to get the canines into class 1. So if you want to get the canines into class 1, you're either going to need to open space distal to the upper twos to make them bigger, to build up the upper twos, the upper laterals, or do some IPR in the lower. And that you can kind of make that decision. All right, so this is where you kind of start moving the teeth. So for me, I'm starting out doing a little bit of molar derotation. Those molars are rotated. I'm expanding a few millimeters, and I can adjust it later when I do the step to bring the mandible forward. I can adjust the amount of expansion, but I'm just doing a rough couple of millimeters of expansion. I use a Lux Creo printer for direct printing. So I usually want my aligners to be in increments of 6 because it prints 12, typically it comfortably prints 12 aligners at a time. So, I mean, if you're using a different printer that has a different number, you might choose a different increment, but I usually use increments of 6. I'm going to start out with about 3 millimeters total expansion, and I'll take it from there. The patient doesn't have a frank crossbite, so I don't think she needs that much expansion. But I know as I bring her forward, if I don't do a little bit of expansion, she's going to be tight in the back. She's going to be a little bit edge to edge in the back. She'll have a crossbite tendency. That's why I'm preemptively doing a little bit, and then I can go and check it later. Okay, and I'm proclining these. I'm starting out just doing a rough setup, taking the teeth to where I want them to be. So the bottom one here is proclination. This one is torque. So if you look at it from the side, this controls the root position. This controls the crown position. So over here, I want to procline those upper incisors. So I'm You can also grab it from here and procline as well. And don't worry about the collision. I'll deal with the collisions later. Right now, I'm just getting them close to where I want them to be. If you want to get rid of the collision, you can just X out of it, and that gets rid of it for you. About 18 degrees of proclination there, so I'll do a similar amount there if they started out similarly with a similar amount. Actually, it looks like the left central needs a little bit more proclination than the right one, but I'll get them so that they look fairly similar. I'm looking at that lingual surface, and I want them to show about the same amount of lingual surface on both of them. And doing just a rough setup of the arch form. And I'm usually over-treating initial discrepancies. So those canines started out with their mesial in, and the lateral started out a little bit labial. So I want to finish up with a little bit of the opposite there. I'll move the distal of the lateral a little bit. This one's going to get its mesial moved a little bit more in. Anyway, I'm just going to get rid of all the gross collisions. Now, the number, the orange number above the collision shows that there's a mid-course collision. So even though there's no collision at the end of treatment, there's a collision that's happening midway. I'll show you that in a moment. We can deal with that a couple of different ways that I'll show you. But yeah, here, again, this is just a rough setup of where I want things to end up. You can see here we have a few mid-course collisions. So you'll see if you go through all the steps, you'll see that here, somewhere around the liner 4 or 5, you get all these, they bump into each other. If you don't address those collisions, it will not track. So you need to make sure you address those mid-course collisions. And there are a few different ways to do that. You can go to auto staging and click fix mid-treatment collisions, and that, you see it increased the number of stages a little bit, but you see it makes them dance with each other a little bit. So it expands a little bit and makes some room around those teeth so that they have room to align without bumping into each other. So that's one way. You can undo from here. If you think you can do it in fewer stages, you can just go, if you want to manually get rid of the collisions, I'm going to switch to advanced mode. See that lock there? You can unlock it. So you could switch to advanced mode, and I could go to stage 4. And at this point, I can do a little bit of, you can either distalize a little bit or expand the arch a little bit, kind of round trip a tiny bit. So go to the plus, click the plus, add a simple key, and you can just expand a little. You can expand and kind of distalize the teeth back into that expansion space. You might even want to expand a little bit here. And you can gradually do that until you eliminate the interference. And usually if you do it manually, you can find a better way to do it in less aligners than the auto stage. So you have the option of doing that if you want to. For this case, it actually didn't end up adding too many additional aligners. So I'm just going to use the auto. So I'm just going to cancel this. I'm going to undo what I just did. You can go X here and just X the whole delete the whole key, and you still have, you know, your. And the navy blue line represents the least number of aligners needed to get the job done. The light blue shows where it actually is, and you see it increased it to 18 or whatever because we went to manual mode and we messed with it. So I'm just going to lock that again, so it's back to the way it was. I'll go to auto staging and fix mid-treatment collisions, and I'm okay with those 20 stages. So it's going from here, it's eliminating the interferences and then ending up there. Lower needs a little bit of movement, not as much. Rotate a little bit over there. Look at it from the front. The right central. Level it. Same thing over there. I'm gonna easily intrude it level it. Incisors. And that canine also needs some mesial tip and a little bit of a trim. I generally, if the bite's deep on these twin block cases, I don't want to correct the whole deep bite by intrude. I'm just leveling out the incisors because I know that I'm going to need to extrude the lower molars to make up for ramal growth. So I want to open the bite primarily by erupting the premolars and molars in these cases. So I'm not really doing a ton of lower incisor intrusion. I'm keeping the incisors pretty much where they are height-wise. I'm just leveling them out. Here we need a little bit of work. Work on those doesn't look that even. And those laterals look a little bit too proclined, so I'll probably retrocline them a little bit. Also over-treat that retroclination that the proclination that they started out with. So I usually want to do about a 0.5 millimeter of over treatment. And usually you want to finalize the alignment before you get rid of before you auto stage and do the mid-treatment collisions. Before you get rid of all the mid-treatment collisions. I didn't quite do that here. Okay, so you're basically turning the patient into a class 2 div 1, basically. Okay, to do the twin block part of this, just a sec. Let me take this back. All right, so if you unlock, you can change this. If you have the tooth selected, it changes the keys by tooth. If you have the whole arch selected, when you change the keys, everything moves together. So I have it in arch mode, and I'm going to go back because I messed up a little bit earlier. I'm going to go back to auto staging, and I'm going to fix mid-treatment collisions. And again, I'm fine with that right now. Over here, I'm also going to get rid of any spaces in the treatment. Actually, we said there's a little bit of a tooth size discrepancy. So I don't mind doing a little bit of IPR. We said it was about 1.8 millimeters. It's about 0.4 millimeters per contact. Should give me that 0.8 millimeters that I need. Otherwise, I won't be able to. And again, your other option is opening space around the upper laterals, especially if you don't want to do the IPR right away, or if you're planning on upper lateral buildups. Again, if you want to get rid of that mid-course collision, you can either go to stage 4 and create it, or just click fix mid-treatment collisions. And synchronize start and end. I'm just having both arches finish at 22. So I'm going to go to the attachments, and this is where you add the twin block feature. All right, so I'm going here to the attachment section. I'm clicking twin block, and I'm putting it where I want it. I usually like to put the twin block around the first premolar area. There are exceptions to that, but usually I like to put it in that first premolar area. I usually like to make it a little bit, so this controls the jaw position, and this controls the block. I'm going to go to the jaw position, and in this case, because she's starting out here, I don't want to bring her to a negative overjet. So I can do incremental transition. So it brings her forward in steps. So as the upper incisors are proclaiming, you're bringing her forward. Or I can have two twin block steps built in. The way you do two twin blocks is you say, okay, this is 22 stages. I'm going to have one twin block that goes just to stage 10 or 11. So this twin block, so then in that case, I won't do it incrementally, and I'll just put two twin blocks in. Usually I'll do it with two twin blocks. Again, that's a little too much, so I can change the amount of sagittal movement to here. So the first twin block's just bringing her forward a couple of millimeters. I'll reduce the vertical there a little. You can look at it from the front. And you don't need a lot of rotation or horizontal movement in this particular case at this point. So I'm keeping her so she has a little bit of clearance there. And then at 11, or at 12, I'll add a second twin block. So here at 12, that twin block disappears. I'm going to go over here, and I'm going to add a second twin block. Same general location, but this time it's going to bring her forward a little bit more. So now she's a little bit more compensated, more decompensated, so I can bring her forward a little bit more. And here it looks like as we're getting rid of the crowding. Just a second, what's going on? Oh, it has this one starting at stage 1. So the second twin block, I need to start it at stage 12. Okay, so this is the one I need to adjust. So this is the one that appears at stage 12. And here I can bring her forward a little bit more. And you can even do 3 twin blocks. Like if there's a lot of decompensation that's happening, you can even have this one go from 12 to 15, and then as the incisors come forward more, you bring her forward even more. Or from the get-go, you can just delete this and just have one twin block that brings her forward incrementally. And to be honest, this might be a good case for incremental advancement, just because she's so compensated. And in that case, if I'm doing it incrementally, then I'll have the final position be a little bit more forward, but it'll get there gradually. So this is where it'd be ending up. I want them to end up at a super class 1 on the molars with a tiny bit of positive overjet. And here I probably need to do a little bit of rotation or horizontal movement. I'll do a tiny bit of rotation here. Again, I'm going to adjust its position a little bit more. I'm going to make it a little bit smaller. The lower component, I usually make it a little bit on the smaller side. And I want the slope to kind of sit between, in front of the slope on that upper first premolar. That's kind of where I want it to live. It still looks like there's 2 twin blocks. Yeah, there's 2. Let's get rid of one of them. So it's just this one that we're using, and it's 1 to 22. And we're doing incremental. And I'm going to rotate just a little bit to get the midlines a little closer to each other. And that's going to have me come back also a little bit more. So that's putting me in super class 1 on both sides. Now I'm going to go back to setup. And here, I'm going to check and see if I did enough expansion or if I needed more expansion. And I'm also going to erupt the molars and premolars so that, as they come forward, the premolars and molars erupt a little bit. So to open the bite, I'm erupting the premolars and molars. Make up for that expected increase in Ramo height. And because this patient's so retroclined, instead of putting 3 twin blocks in, I'm doing it using that incremental tool. I'm erupting them until they meet each other there. And I'm looking over here, and maybe I expanded a little bit too much. I could reduce that a little bit on that side. On this side, it's actually not bad. This one might be, the first premolar might even need a little bit more expansion. And obviously you're kind of messing up the collisions again here, so you need to go back and fix the mid-course collisions again. It gets rid of all the auto staging if you start moving the teeth again. Also go back here and get rid of these. We're almost done with this. And I'll go back and just do that auto staging, fix mid-treatment collisions. And again, I know I can get it in, this is an 18 stage case. I can manually get rid of those collisions and have it be 18 stages instead of 22. But just for the purpose of time here, I'm just going to let it be. Go to the attachments. It's asking if I have, so stay and fix. Where is the mid-course collision? Okay, so in the lower, we still have a mid-course collision. Okay, so we're good there. I'm going to my attachments. Now I'm looking at which teeth I actually need attachments on. And on this patient, got my favorite attachments, and so I'll usually use a 2.9 or 3 millimeter wedge-shaped attachment or horizontal bevel. And I know those upper centrals need a lot of torque, and the attachment auto-orients with the force. I know I'm going to need them on the laterals. And you lose a little bit of aligner retention when you have that twin block feature. So I'm adding a little bit more. I'm having the attachments appear at stage 1 for these cases, because I don't want it, I want them to be comfortable with it. I want it to grip well. And for that, I usually need to start the attachments earlier. So for here, like this one's probably need to extrude a little bit. So I'll put an attachment there. It also has a little bit of tip on it. I'm putting attachments on the canines. Lower canines almost always need an attachment. And then I know I'm extruding those molars and premolars. So here I'm actually going to even increase the profile on that a little bit to make sure it grips well. Maybe we put too much there. Because I know those molars and premolars are going to have to extrude, so you want to get enough grip on the aligners. That's a challenging movement for the aligners. And then in the upper, I'm putting some attachments on the upper canines. And then the upper first molar also for grip. Because I know I've got that twin block feature, which is making me lose a little bit of aligner grip. And maybe that could be a little bit lower profile than that. Okay. So this is kind of where I'm at. Let me just go back here. So that twin block needs to be adjusted a little bit. So as it's moving forward, it's changing position because it's incremental. If you're doing it manually, you don't have to deal with as much change in the twin. It stays where it is. And you can adjust the position of the twin block, even if you're doing it incrementally. So I could have it start here. And that way it's changing the upper more than changing the lower. You can see it bringing one side a little bit more than the other. And I want it to end in the same position there. Okay. All right. And then this way the upper is what's changing position, not the lower. And I don't mind the upper changing that way, starting out bad in the back and coming forward. I don't want it doing as much of that in the lower because I want those attachments to engage. All right, so I'm going to the next step here. Now we're just setting up the tags. So I do direct printing of shape memory plastic. So with that, I still need to make the template out of it. You can't use that material for a template without using a separating medium, and I generally don't want to do that. So I'm using a regular printer to make a template, or you could send it to the Titan lab and they could make you a template for as well as the aligners. But I'm labeling the model. And here, since I have attachments on the first molars, I can have my number on the lingual. And you can customize this to include whatever information you want. I used to put smaller numbers, but patients couldn't see them. So now I just put a nice big number. And then treatment series, if it's the first round of aligners, you can put an A or a B after the number. Or you can put patient initials if that makes sense for you. All right, I'm going back to ready. I'm going to my cutting line here. So you have some tools here to help you with that. So if you want less scalloping at the frenum, if you want the whole buccal anterior to be a little bit higher, you can go and kind of manually change these dots a little bit if you want to. In this case, in the maxilla, on the lingual, the anterior, I basically want to include the palate. So I might actually have to go here and manually move this to include more of the palate, because I want it to include more of the palate. Since I'm doing a little bit of expansion, I want that extra grip on the palate. But yeah, that's your line. So the cutting line is important. If you're sending it to the lab, it's not as important. It's more important if you're gonna be direct printing the aligners, or if you have a trimmer. So a lot of people use vacuum form aligner manufacturing, and then we'll put the aligners in a trimmer. So if you have an automatic trimmer, you want it'll follow the trim line there. So that's important for that as well. And then you go to ready and print order. So this is kind of where, if I'm printing it in-house in my lab, I'm picking my lab, and I do 6 at a time because that's how my printer works best. So I'm going 6. I'm changing the aligners every 10 days, sometimes every 14 days. If I'm using a twin block, I'm keeping them in each aligner for a little bit longer. You can pick, so this is gonna batch it so that you don't have to store 22 aligners, so you get them 6 at a time. And it also organizes the workflow for your lab. So if you have a lab person, they don't have to make 22 aligners at a time. They're going to make 6 stages, and then when it's time for the next one, based on the aligner increment that you put up there, they're going to schedule it for them. Here you can write some notes to the lab if you want them to, don't the palette, or if you want them to, make it out of a different material, you can do that. In the twin block section in the beginning, you could also pick whether you want it solid or hollow. There's corrugation in the twin block, and that helps give it a little bit more rigidity. And on those 0, I have a template for stage 0. If you want models to be sent to you, if you want an aligner case, if you want retainers and stuff like that, you can pick that there. And here you pick the type of material if you want the lab to make it. I'm having my lab make it, but if you're sending it to the Titan lab, you can pick the Titan lab over here. or whatever lab you're picking. There are other lab options as well. And you can, if you're sending it to the lab, I would have the twin block made in 040 because they're in it for longer and because there's a lot of stress on that twin block area. So I'm using either 040 or I'm using the grinder material, which is the BRX is similar to a C plus from Raintree Essex. So it's what we use for people that for retainers for people that grind on their teeth. So you can either use 040 Atmos or use the BRX, the grinder material. And you go to next, and here you see the batches with the date. So this is if I sent this to the lab, you'd be getting these in this order. And I'm not going to submit this, but I'll show you where this patient ended up. So let me cancel this. Let me close this out. And now I'm not really doing anything with this, so I'm just going to delete it. But I'll show you where this patient is in real life. So at the end, and I'll show you the actual setup that we did. So I had 21. This was before I was doing direct printing. So this was the actual setup that I did. Let's see if I did it incrementally or not. And I did do it incrementally here because those upper teeth were so retroclined. And I'll show you where the patient ended up at the end of that round. So the first round was 21 aligners. The second round was 13 aligners. And we'll see where they ended up. So this is what they looked like at the end. They were tripoding, but not enough. At this point, I actually might have even been better off just cutting the lower aligner and letting those molars erupt before I scanned for the refinement. I guess I didn't, and I scanned for the refinement. And I think this is also, this was a while back. This was before I was planning the eruption of the molars in the aligners. Now I'm doing a lot more of that. This case was probably before I was doing that. So you'll see here in the next round of aligners, I have some buttons cutouts. And I want to wear the aligners to the actual buttons on the teeth because I want to help them erupt a little bit. And we have some new attachments. And I'm going from here to there. And that's 13 stages. And then just December, a few months ago, we scanned her for one more refinement. And that's 6 stages. And I'll show you where she's actually at this point. So we did not build the upper laterals. We're still getting those molars to erupt a little bit more. She's still a little bit class 2.
Anita, adelante, por favor.
And we're still using some rubber bands to erupt that mesial of the molar a little bit more. And I put some bite turbos there on the upper just also to help those molars erupt and open the bite a little bit more. But she's getting close. And you can see we did some IPR here just to help get her to fit better in the front. I guess I hadn't done the IPR at the beginning. So this is it for today, and I'm happy to take some questions if you have any. Jose? Jose?
Hi, Dr. Mohamed. This is Laura.
Hi, Laura. How's it going?
I'm doing good, thanks. So we actually have a question here on the chat.
Okay.
It says from Dr. Bradley, it says, Dr. Masoud, what is your reasoning and why do you prefer 2 twin blocks instead of incremental?
I think that, so the reason I prefer 2 twin blocks is that most patients don't need this much decompensation as much as this patient needed it. So if it's just a little bit of decompensation, I don't want to waste the first 6, 7 aligners on like 1 millimeter of advancement. So if I'm doing it incrementally, it's bringing them forward really, really slowly. And if the, I don't know if my camera is, let me see if I can turn my camera on here. Okay, Let me stop sharing. And let's see if you guys can see me. Okay. Nope. I'm not sure. Can you guys see me?
Yes.
Yeah, okay. All right. So if you are doing it incrementally, you're bringing them forward at a really, really slow rate. So you're not going to get a significant advancement until they're like in stage, 8 or 9. And that's fine if you're starting out with a lot of decompensation, because you can't bring them forward. But if I have a choice, I want to bring them forward halfway. I want to get a good 3-4 millimeters in the beginning and another 3-4 millimeters in the next step. So I think it's easier for them to adjust to stepwise advancement, but I think the incremental does it in steps that are too small for me. So unless they're extremely compensated, and I'm going to be so if they're very, very compensated, I think the incremental is fine, because that amount of the change in advancement is similar to the decompensation that's happening. But if they're not extremely compensated and I can bring them forward, 3-4 millimeters in the beginning, I want to get more correction earlier. I think the compliance is always better in the beginning, and 2 or 3 millimeters they can easily adapt to, and then halfway through I'll put the next one in and bring them forward the next step. I think you don't waste as many aligners in the beginning on an insignificant amount of advancement if you can afford to bring them forward a little bit more. I don't know if that answers your question, Brad. Any other questions?
Apparently no, Mohammed. Really, really nice presentation. Love it.
Thank you. Appreciate it. Thanks, Jose. All right. So I guess I'll see some of you guys maybe at the AAO in Philly or the next meeting. Thank you.
Thanks to you, Mohammed.
All right. Thank you.
For the
Thank
rest,
you very much.
for the
Thanks.
rest of people in the presentation, it's going to be saved in our YouTube channel. Okay?
All right. Thank you so much. Thanks everyone for attending.
Thank you. Bye-bye, Mohammed.
Thanks, Laura. Thanks, Jose. Bye.